It's great to be here at the Royal College of Emergency Medicine first ever conference here in Manchester 2015, and my presentation to conference is about the future of emergency medicine in the UK. There are lots of key challenges facing us at the moment, but the most important one that I want to talk about at the moment is how we reclaim the emergency component of whether you call it an accident emergency department or an emergency department. Currently, far too many people have no other option when they have an urgent healthcare need but to attend their local A&E department, and so it has become, despite our best endeavours, really an anything and everything department for people with urgent care needs, particularly out of hours, nights, evenings and weekends. People have talked for a long time about renaming these departments emergency departments in the hope that rebranding ourselves would actually change behaviours and change perceptions. And unfortunately, I think that's highly unlikely to work. What we need to do actually is embrace the term A&E, but no longer associate everything that happens in an A&E department with emergency medicine. Emergency medicine is a subset of what happens in an A&E department. It's a subset defined by the curriculum of the college as examined in our membership and fellowship examinations. And it's a subset which you and I practice every day, every week, in every department in the UK. And it is focused very much on the acute illness and injury of paediatric and adult patients, including mental health problems. But it doesn't encompass everything that may cause people to attend an A&E department. We shouldn't turn these people away saying, I'm sorry, this is an emergency department, you shouldn't be here. Please go to this other place which may or may not exist and may or may not be open. What we should do is create an A&E hub, or an A&E village if you like, of which the emergency department is but a subset. Alongside that, we should have things such as community pharmacy, out-of-hours urgent primary care services, links to community mental health teams, links to district nursing, possibly even links to dentistry and social work. This isn't a new idea. In many ways, it's an evolutionary idea. Many places do already have some degree of co-located primary care services, but we know that 60% of A&E departments, as currently named, do not have such co-located services, and they need to be developed quickly and across the country. This way we can tell our patients that it's not for them to second guess whether they're a bit ill, very ill, or life-endangeringly ill. It's not for them to work out what the possible diagnosis is. They present when they are concerned and they have an urgent health concern. When they arrive, we see them, we sort them, we triage them, and they are placed into the correct pathway for their care needs. Now, any triage system will have weaknesses, and it's possible that people will be wrongly triaged. That's why co-location again wins out, because if we have incorrectly triaged you to a service which we then find is not the most appropriate for your needs, it's then really a very simple matter to move you 10, 15 yards across the corridor into the right service. In this way, we stop trying to fight against the tide of people who attend our departments. Instead, we provide them with the services they are perfectly entitled to believe they should be able to access on a 24/7 basis, though accepting that many of those do not fall within the remit of emergency medicine. So what I am calling for, and what the college is calling for, is a recognition that emergency medicine and emergency departments are a subset of what may be co-located within an A&E hub. The other key message that we're giving today is that many patients arrive in an A&E department for perfectly reasonable reasons, but again, they don't require an emergency doctor. These include such patients as those who've been discharged from the hospital within 24 hours for the same reason. Unless these patients need resuscitation, they should be returned promptly to the team that was caring for them before. A subset of these are patients with post-operative complications. Now, when I was a surgical house officer, most post-operative complications happened whilst the patients were still inpatients on a ward and therefore were seen directly by the surgical team. Nowadays, with shorter lengths of stays and increasing amounts of day surgery, people have a post-operative complication in their own living room. They then present to the hospital to the A&E department. But I have no particular expertise or skill in the management of these sorts of problems, and they should be passed quite quickly to surgical teams better able to cope with their needs. Other examples of this include people with dental problems, people who've seen an optician, patients who've seen a general practitioner. If the GP was of the opinion that the patient needed to be seen by a specialist team within the hospital, then who am I to suggest otherwise? And we should simply direct and expedite the movement of that patient to that specialist team or vice versa. In this way, we can substantially decongest our departments by focusing on our core business, which is emergency medicine, not anything and everything that may arrive at an emergency department or an A&E department 24/7. These are the key focus points of the college over the next 12 months, bringing greater clarity as to what can and can't be delivered by emergency medicine and what should and should not be delivered by emergency departments and A&E departments.